All right, so this week we're going to return back to a topic that we discussed in the earlier part of the semester, and that being on suicide and looking at the assessment process. So, some of the learning objectives I hope to be able to pass forward would be able to look at the statistical trends in terms of national suicide rates. We're going to look at those risk factors, protective factors, as well as warning signs. All right, so first we're going to take a look at how we would approach and face the suicide situation. To start with, I like to show a video, and this is of the Summer Flanagans discussing as far as how we as clinicians have to deal with and handle suicide.
You've now reached the place in the textbook where we cover suicide assessment interviewing, and that's a difficult topic. And I'm going to share a story that's not a very fun story either. Years ago, I was working with a 15-year-old boy, and he ended up dying by suicide. And it was terribly traumatic, obviously, for his family, and also to some extent for me. And I remember being in really not very good emotional shape afterwards. And so one of the things that I learned from that is that it's really important not to isolate yourself or to face those kinds of situations where you might have a client die by suicide, or even if you work regularly with clients who are suicidal. Either way, it's so important to have a support group. Rita was a great source of support. I had a consultation group that I went to and got some really good feedback and support from. Yeah, so that's, to me, the moral of the story. The main thing that I learned from that experience was how hard it is, how scary it is, and how important it is to not go there alone.
Yeah, I want to underline that too. You just do not know if you'll have a client who dies by suicide. Of course, there are standards of care and practice guidelines, and hopefully you'll be well aware of those, but sometimes it happens. And it will be natural to feel guilty, to feel regret, to feel like you missed something. And it's very important to, both for emotional reasons and legal reasons, to have a supervision group, to have personal support as you sort that kind of experience out.
You might even need or want your own personal therapy. Now, I know we're sounding kind of depressing right now, and I want to reassure you that in most cases, almost all cases, you will be able to function as a mental health professional, as a clinical interviewer who helps to preserve life and who helps people move past or through and work constructively on the kinds of suicidal thoughts or feelings or impulses that they might have as they meet with you. And so even though we've started with a kind of a depressive story, keep hope, and you will make a big difference in many people's lives.
All right, so with that understanding, this is one of those, I would consider it to be one of the hardest parts of our careers as psychologists, is working with individuals who are demonstrating suicidal ideations or who have had suicidal attempts. Treating suicidal patients, technically speaking, is a difficult task because suicidal behaviors is extremely complex, and it's multifaceted in the sense that when you're treating patients who are suicidal, you're dealing with their emotions, which is difficult in itself, and there's so much at stake. Their life is at stake. So when we're looking at a potential suicide, uh, and we know that this is an emergency, we really, as therapists, have to look into not only the client in terms of patient suicide and the professional element, but we have to also recognize our thoughts and our actions and be aware um, of what's going on with us. You have to understand, if not some, all clinicians, this is their worst fear. Okay? Almost every psychologist is going to discuss or talk about this fear in some sort. And when we're treating suicidal clients, it's dealing with ambiguous situations, because even when we have the best type of predictive models that we're looking at and using, there's still going to be a high rate of false positives. That being that those who are treating suicidal clients, they'll know things out of the blue will go wrong. Everything can be looking upward in your assessment process, in your interview, and then it can just spiral downward. Or you could have had a situation in which you worked with a client, and you was able to at that time assess that they wasn't an immediate danger to themselves. Thus, you created a plan, you allowed them to leave, and then you get a call an hour or two later saying that that person attempted and killed themselves. So when you have a patient die from suicide, realize this is an occupational hazard for us, okay? And I don't care how skilled you might be in doing psychotherapy, when you have a client die from suicide, it's going to hit you hard, and you're going to worry about whether you're truly competent to be able to work with your clients, because having your client die will make you feel like you didn't provide appropriate care. Realize though, 50% of psychiatrists and 25% of psychologists have discussed and stated how they had a patient die from suicide. I can include myself within that statistic. Working in Alaska, I dealt with suicidal clients on a regular basis. Uh, Between 4 to 7 suicide situations weekly. So the good news, well, I don't know if I could call it good news, but I can say the more it, the good thing that happened for me as a therapist was that out of everyone that I worked with, I only had one loss. But that one loss was devastating in that it was where I was actually not the primary psychologist over the case, but I was the supervising psychologist. Um, and I was working with a social worker whose client that person belonged to. And we worked with that client. We flew out because they were in a village. We brought them back to our village, worked with them, had them actually go to Alaska's psychiatric unit, had them come back and stay with us because we also had a transitional house for our more serious patients, mentally ill patients. And we did everything that we can, and no sooner than they were released and they went home, they took their 4x4 and ran straight into a tree. So there are times when you're thinking that everything is going great and it spirals down to the worst case scenario. There was a survey done, though, that discussed how at least 4% of people in the Pennsylvania Psychological Association discussed how they had at least one patient die from suicide within the last year, and that was back in 2017. So suicide represents a tragic loss, uh, and the sacred life is something that is what we contend and deal with as a loss. We know that the families, be that their spouses or their children, they're losing their parents, or the parents have lost their children, siblings and friends are losing loved ones. And according to a general social survey that was conducted back in 2016, 51% of Americans reported knowing somebody who died from suicide. And at least one third of those, they reported being bereaved by suicide. Now, for close friends or relatives of suicide victims, these scars can last a lifetime. And a lot of times the survivors will start blaming themselves, or they'll start asking what is it that they didn't do? What could they have done differently? This woulda, coulda, shoulda starts popping. Those irrational thoughts starts to pick up in their mind. And it develops into social type stigmas um, in regards to suicide. So imagine that a person, neighbor might say, well, what kind of parent drives his child to a suicide? You see what I'm saying? Families, they have to now deal with the stigmas that can become attached, that's now flowing negative thoughts into from the community. There have been times when you think about how you would say things to a person who lost someone to suicide. That's a difficult battle in itself. But overall, one of the things that I want to mention, and some of these things that I'm talking about actually comes from uh, Samuel Knapp. He's some information I'm providing today is coming from suicide prevention, but he discusses how there's been development of looking at adjustment disorders, looking at the DSM-5 as well as the ICD to help to create more type of uh, classifications for more severe forms of mental illness that we might not even be catching, because suicide in itself, although it's a discussion, although we know about it, there's still never too much that we cannot get from it. And Knapp's feeling is that really we need to have this as a disorder all on its own, that we can give better emphasis to. So one of the things that you have to look at in terms of your stress is how do you deal with what's your personal reactions. In the video, you heard how you need to develop a support network for yourself. Be that if you start going to therapy on your own, be that if you have a mentor that you can consult with, you need to make sure that you have coping strategies in place for you. It's extremely important. The other thing we have to realize and understand that in working with it, we talk about the ethical and legalities of working with people with suicidal ideations or suicidal attempts. So you need to keep in mind some things that can help guide you through the process. Okay, so I put up a few that I think would be helpful in this situation, but of course, because y'all all have had ethics training, if there are others, by all means, do share. But principle A, beneficence and non-maleficence. Here, of course, we're striving to benefit those we're working with. And so our number one goal is to do no harm. We work toward safeguarding the welfare of our clients, and we do that in a professional manner. But I want to say, when I say this, that one of the hardest things to do is not allow your personal feelings and thoughts cloud you during this time, because you are dealing with yourself being highly emotional. You might not think so. You might be able to feel that you could keep the professional hat on, but you actually will be dealing with a lot of raw emotions as you're working with clients, particularly if you had any previous clients who did succeed in killing themselves. So that's one area you want to be considerate of. And then in terms of principle E, we respect respect for people's rights and dignity. Here, our goal is actually to try to exemplify one's dignity and their rights to live. So this is something that you would want to be able to follow, because we want to make sure that everyone we work with have a sense of worth to them, to reiterate that they're not hopeless, that they're not helpless, that they empower so much more than they could feel at this moment. Being able to provide that is allowing us to say that we are following the ethics code. Now, I put down standards for 2.02, providing services in emergencies. And I'm kind of doing that because I'm thinking about right now. We're in a crisis, and we are working on crisis mode more than regular therapeutic mode. At this time, you're really not doing assessments per se, but you are checking and making sure, and you're assessing to ensure that your clients are not in a crisis because of the pandemic. But in that situation, we have to make sure that during emergencies, psychologists can provide individuals with whom may not have the regular mental health services available to them. We can provide them with services even if you're cross lines. And what do I mean? Say, for example, a one of your clients lives in Chicago and you're in Jackson. Okay, well, we have two different psychology boards to contend with. There are ethical issues trying to understand what's allowed in terms of telehealth in Chicago in comparison to Mississippi. Now, we do know that there has been a lot of leeway given in terms of telehealth, but it's still things that we have to consider and have to know. Understand though, if you get a client who is suicidal and they're in Chicago, your first priority is to make them safe. So that's why that's there and that's included. Okay. Next thing I put down was 2.06, talking about personal problems and conflicts. And I included that because we have to refrain from initiating activities when we know that it might be detrimental to our providing appropriate services. Here's where it's difficult. Our emotions is a part of us. You can't get rid of that. That's who you are. But if you know that when you're working with your client and you find that your personal thoughts, your personal opinions is really clouding your therapeutic uh, rapport, your therapeutic duties, then that's when you have to consider, I need to get a way to find better services for my client. That might mean you need to get on the phone with your supervisor right now, since we're doing telehealth, and have it where it's co-facilitated, where it's a three-way conference call if you're using telephones. Um, you want to make sure that there's no conflicts being created because you're struggling with the fact that this person might be suicidal and want to die, and you might be having what I call the imposter complex going on, and that you don't think that you can truly help this person. Those are the type of issues that can actually impede on the therapeutic relationship. It can impede on that crisis situation in a way that you don't want it to. So you want to, of course, maintain that, which leads into 3.04, avoiding harm. We are not to bring any harm to our clients, period. Um, Bottom line is we need to be able to make sure that the environment, being that this is a different type of environment altogether now, we're talking about using a telephone, or if it's some way that you've been able to link up with GoToMeeting or Zoom, all these different facets, then we need to make sure that what we're doing will not actually impact the client negatively. So those are just some of the different ethical considerations you should be thinking about. I'm quite sure there's more, but these are some that came straight to my mind in terms of working with your clients. Now, I just wanted to point out, and it's kind of small, and I'll probably try to, if I can remember to, include the file on Canvas under the. Now, talking more about some of the statistical data and information, looking at the public health importance in regards to suicide. Just to speak about the stats some more. Now we're going to start talking about some of the risk factors that would be involved. And of course, I'm going to start again with the video, and then I will continue a discussion thereafter.
There have been a number of recent changes based both on clinical observation and research regarding suicide risk and protective factors. So, John, talk about some of what's new in this important area.
Well, of course, risk and protective factors and warning signs are all really very important. But we have to be realistic. Even though there are risk factors, they don't really allow clinicians to improve their prediction of death by suicide. And so really now what people are thinking is that we use this information about risk and protective factors and warning signs more to help us to have unique and idiosyncratic discussion with each client about what's going on with the client that may increase risk or decrease risk in that individual. The problem is suicide occurs at such a low base rate that it is impossible to predict, even though we know that there are some risk factors.
All right, so in continuing or piggybacking off of what the Summer Flanagans was talking about, some of the things in terms of risk factors is looking at some of the psychological disorders that we have to consider to be higher risk. That being depression, and understanding the relationship between depression and suicidal behavior has been well established through research. Clients that demonstrated depression are more than likely to follow demonstrate higher risk towards suicidal ideations as well as attempts. Then, of course, we have to contend with post-traumatic stress disorder. Here again, a person is dealing with their ongoing symptoms of, it could be flashbacks, it could be throwing them off due to that tragic event, which is going to trigger one to end it all, pretty much. And so that can be considered a higher risk. Bipolar disorder. And the main thing that I just want to do as a reminder, I kind of feel that everybody has an understanding in terms of bipolar disorder when we're going through a psychic phase. We have to be really careful when a client is coming out of that depressive state and moving more toward a manic state. This is the time when they're thinking that it's easier for them to be able to now carry out a plan than it was when they were in that more depressed state. We also look at substance abuse and dependence, schizophrenia, borderline personality disorder, as well as conduct disorder, insomnia, as well as post-hospital discharge. As I mentioned earlier at the beginning, and I spoke about the client that we lost to suicide, this was right after them leaving the hospital, right after them leaving clinical care, that they went and no sooner than they was back home was able to attempt and succeed in killing themselves. So that is definitely a risk factor that we have to consider. And then, of course, we have to be careful about SSRIs because sometimes it has that impact. One particular medication that I always am worried and concerned about is when people are trying to quit smoking and they start taking Chantix. Had a lot of people through the trials demonstrate and show that they was getting suicidal ideations because they actually was feeling more depressed because they was dealing with both the changes coming from the medication as well as that decrease in nicotine, which was increase in withdrawal. And it had a heavy impact on those individuals. So knowing that that can be a risk factor, these are things that hopefully will allow you, when you know that you're talking to a person and they say, well, yeah, I used to smoke, you might want to know how long it's been uh, for them to stop. You might want to know how they stopped. Is it that they're taking medications? If the person is in a depressed mode, I have a person that they were just put on, and which drug was it? It was an antidepressant. I'm trying to think which one. It was an SSRI. Can't remember the name. But of course, we know that it takes at least 30 days before that half-life builds enough to kick in so that the effects of the antidepressant starts working. And for that individual, they felt even lower because of feeling more lethargic in the process and not seeing instant results, which made them even more suicidal than they felt they were before. So that's something we have to be careful about. All right, so other factors that we have to look at is that the social, personal, contextual, and demographic factors. Is the person alone? Are they isolated? Are they connected to their family? Now it's time to start looking at how we can help a person. So we're going to talk about protective factors. And protective factors against suicide pretty much is going to be those personal factors. Now, looking at warning signs. Now, there's a lot of different literature out there trying to come up with some ways that we can. Now, on this, usually a lot of times we talk about suicide and we talk about the things that we need to do, but there are actually theories available for us to utilize. And so, all right, so I'm going to stretch for a second.
We evaluate
Now,
clients using a
finally,
clinical
for
interview.
this
And
particular
assessment instruments, of course,
video,
exist, but they need to be
we're
used
going
in
to look at a
conjunction
sample
with the
of
suicide
an
assessment
assessment
interview.
interview.
Assessments
And
would work better, of course, if you
hopefully
have
you'll
a
be able to take
therapeutic
some
relationship.
notes.
So
I
making that
want you to look
interpersonal
at
connection is
how
very
you
important.
see,
There's an
would you do
acronym that's
anything
useful,
differently?
RIP-SKIP. It's in the book,
Again, everybody's
and
going
it
to have their
helps you
own
remember
style.
which areas to cover.
Summer
Maybe you can make
Flanagan,
a
he covers
list and
some
see
things, and
if you
there's
can
some things I
identify
wish he could have did
the
differently.
elements of
And
RIP-SKIP
so for your
in the video
assignment
with
for
John
this
and Tommy
particular
later
area,
on.
and I might put the video
In
back
this
there
next clip,
again so you
I'm
can
going
just
to be
refresh your
using a
memory.
rating scale
But the
with a
question
suicide
is,
floor.
what would you do
And the purpose
differently?
of the rating scale
All
is
right,
to
so
help start a
I am going
conversation,
to
if it's
start the
needed, about
video, and then you're
suicide
going to see
ideation.
my video go black. You'll probably see me reaching over to
Kobe,
cover it,
I'm going to, if it's
because
okay
this
with
part
you,
of the
ask you
video
some
is about
questions
30,
about your
35
mood.
minutes.
Okay.
So
Is that all right? And
Hope you get
so
something out of
what I
it
want to
and
start
do
with is
enjoy.
with a scale.
Okay.
And the scale starts at the bottom, the very bottom. As low as it can get is 0. Okay? And 0 means that you are so down, your mood is so down, that you just want to die. Okay? It's the very bottom. You can't get worse than that.
Okay.
And the very top is 10. And 10 would be the best mood, the highest, most positive mood that you could have.
Okay.
And maybe you'd be dancing or singing or whatever you do when you're really, really happy.
Okay.
And so what would you rate your mood right now?
I would say probably a 3.
Okay. So about a 3 now. And what's happening now or today that is making it a 3?
I just feel that my relevancy or my reason for being here, I don't feel like there's a reason for me to be here anymore.
And the way you say that makes me think that 3 is lower than average for you. That's
Yeah.
a bit down.
Yeah.
And you don't feel relevant. You don't feel like there's a reason for you to be here today. And what would you say is average for you if 3 is below average?
I don't know that anybody really ever gets to a 10. So, I don't know. I would probably say an 8.
So maybe for you in your regular life, being around an 8 feels about normal. You're significantly below that now with a 3. In the last month, what would you say is the lowest rating that you've had for your mood using that same scale?
Oh, well, 1, definitely, so there's just, what's the point?
So you're down to a 1. Probably a 1 involved some thoughts about suicide. Okay. And what was going on then that took you down even lower than a 3, down to a 1, so you had some thoughts about suicide?
Lots of changes happening. I don't matter anymore.
Any particular changes that took you down to that 1 and made you think, I don't matter anymore?
My oldest son got engaged, and I'm happy that he's happy, but then I'm old and I don't matter anymore.
So that's an incident that you're happy for him, but it sort of makes you feel like I'm irrelevant.
Exactly.
Yeah, what do I matter?
Yeah.
During that same last month, what would you say would be the highest or the best mood rating that you've had?
Maybe like a 6 or a 7.
Okay. So in the last month, overall, even the best times, you're a little below what your average. When you were at a 6 or a 7 in the last month, what was going on then that might have brought you up?
Just a celebration and having family around and being connected with my family.
Yeah. So the family around and the connection with family is something that tends to bring you up, would that be true?
Definitely.
And then it seems like the stuff that brings you down are some repeated thoughts about whether you matter anymore.
Right.
And are there situations or times of the day when those thoughts become more frequent, that you're not relevant?
I would definitely say when I come home to an empty house and it's just me.
So that might be a time when it's more likely for you to have a suicidal thought too, along with thinking that you're irrelevant. How often? does that happen? How often has that been happening, I guess, over this past month?
Well, weekly,
At
if
least
not
once a week,
daily.
maybe sometimes it feels like every day.
Mm-hmm.
Mostly at home at night or by yourself, or are there other times of the day when it seems to pop up?
I think I'm busy enough during the day that it doesn't really, but when I'm home and it's just me, I think about it a lot.
Yeah. So one of the situations that triggers the feelings of being irrelevant and suicidal thoughts is when you're alone and lonely and not engaged in distractions or activities like you might be at work.
Yeah. No.
Okay. Have you ever had a time when you were down at a 1, let's say, a 1 or a 2, and you're having some suicidal thoughts, but you managed to just, even though you were still alone, you managed to start feeling better somehow?
Well, yeah, but that's more just because I think about how I just, even though I'm not relevant and I'm there by myself, I wouldn't want anyone to have to deal with the outcome of that, I guess. But I go back and forth, so I don't know. It's not really like it makes me happier. It just keeps me from following through with it, I guess, maybe.
So it's not so much it even boosts your mood much, but it is sort of something that helps you think, I don't want to kill myself. That's not what I want to do. That sort of stops you. Now, as we do some work on this, one of the things I would like to have us keep in mind together is we've got this scale. And it sounds like for you, when you're down at a 1, that's a vulnerable time. It's a risky time. And it's a time when it would be useful for us if we can talk about how do you go up to a 2? How do you get up to a 3? But some small steps. I mean, even 1.5, right? Mm-hmm. Just to think about how you make a small movement up when you're in a down place. And today you're a 3. And you're talking with me openly, and I appreciate that. But one of the things that's helpful is that sometimes when you're at a 3, and maybe you're not having some suicidal thoughts, it's a good time for us to talk and make a plan for if, when you're home alone, sometime you start to have them, so we can have a nice, clear plan that you can enact to help possibly increase your mood to 2, reduce the intensity of the thoughts about suicide, how often they come.
Okay.
Is that something that you'd be willing to work on?
Sure.
In this section, we're going to demonstrate a suicide assessment interview. We're going to see John working with a young woman named Tommy, who's been referred by staff at Trapper Creek Job Corps, where John has seen Tommy one other time in a group setting. So he doesn't know her very well. The staff is worried about her because she's moody and she's had intermittent suicidal ideation, so they want a mental status sort of check-in on that. You will see as the tape begins that we're a little ways into this session. John started an assessment of mood and depression because Tommy's indicated she's a little bit down. And also she's talked a small amount about her family troubles and some other areas of concern like personal insecurities that are affecting her mood. So we'll go ahead and watch some of this tape.
I know from our conversation before also that you're native Alaskan.
Yes.
And you're from a tribe in Alaska. That's your main tribal connection.
Yep.
And that's the
Yupik. The Y-U-P-I-K.
Y-U-P-I-K. Okay. And as we're talking today, if there's anything that maybe from your cultural background or from your tribal perspective that I maybe am not getting, I hope that you would feel free to say, hey John, from my perspective or from my cultural perspective, this is the way we think about it, or this is the way we do it. And so would that be okay if you let me know if I'm going the wrong direction? Or
That'd be fine.
okay. All right. And sometimes when people are down, it affects them in a lot of different areas.
Mm-hmm.
And one of the places that can affect you is the way you think. Okay, it can affect some thoughts that you have about yourself,
Yeah.
or about the world, or about the future. So I'm wondering if you, in particular, you're having any negative thoughts about yourself, or the world, or the future outlook of things.
Sometimes I feel really hopeless.
Mm-hmm.
I don't know, like, things seem to get worse all the time.
Mm-hmm.
So I don't really think about the future.
Sometimes people, when they're feeling down, they have some physical symptoms too. Like sometimes people have trouble sleeping, sometimes they have trouble eating, or then sometimes they sleep too much and sometimes they eat too much. Have you had anything like that going on?
Yeah. I haven't been sleeping. Can't really sleep when you're too busy thinking. So
your mind is kind of buzzing along
mm-hmm.
at night, and so it's hard to lay down and really get yourself to go to sleep.
Yeah, but once I do sleep, I don't want to wake up.
Yeah.
I'd rather stay asleep and dream and actually have to wake up and deal with reality.
Yeah.
So
Sometimes people have their social relationships sort of affected by when you're down too, and I'm wondering how your social life is going. Is it going okay? You have some contacts and connections?
I have friends, but I don't know. It seems like everyone's having fun, and I'm there just to be there.
Mm-hmm.
Like, they call me a zombie.
Mm.
So.
I'm going to just ask this question directly, Tommy, because sometimes when people feel down, it's really not unusual for people to also think about suicide or about death. And I'm wondering if you've had any thoughts about suicide or about death and stuff like that.
There's been some.
Okay, so you've had some thoughts.
Yeah, more than some, probably. Daily basis.
Okay. Think about that most of the day, part of the day.
Whenever. Sometimes it's never, but maybe. Sometimes it's like throughout the day, but.
Okay. What are some things when, what are some times when you're not thinking about death or suicide? What's usually going on when you're free from those thoughts?
When I'm not thinking about suicide?
Yeah.
Probably singing.
Okay. When you're singing?
Mm-hmm.
Okay. So kind of engaged in making music in some ways, and that sort of takes you away from those more negative and sad.
Yeah. I write poetry too.
Okay.
So.
And that's helpful?
Yeah.
Okay. sometimes when people think about suicide, they think about it in a very active way, like, oh, here's how I think I would kill myself. And sometimes people think about it in a very, well, a less active way. It's like, oh, I just kind of wish I was dead. But I don't really have a plan or any specific ideas about how I might end my life. Which is more true for you? Do you have some specific ideas about a plan or a way that you would end your life? Or do you just sort of think, oh, I wish I...
Well, I have a couple plans, but there's days where it's inactive.
Inactive in that it's not...
It's like, I wish I was dead.
Okay.
Or the world would be better without me or something like that.
Okay.
So I could hurt the people in my family and they would feel bad for it. But I was either gonna shoot myself, but that was out of the plan because there was no guns in the house. So I was going to hang myself in my room and write on the walls everything that ever hurt to me to my parents. So whenever they decided, wow, she's been in her room too long, they could go in there and ta-da. Yeah.
So one of the parts for you is to send a message to your parents about how you feel about how you've been treated.
Well, it's certainly clear that not all of these interactions are scripted or planned ahead of time. They're very real, and so they're not perfect. We'll talk about some things that happened that went well and some things that maybe you wish you'd included.
Right.
So one thing I noticed right away was kind of an interesting where she spelled the name of her tribe, and at that moment in the interview, her mood lifted, she smiled. It's kind of interesting.
Yeah, I noticed that also. I thought it was interesting. I'm not sure what to make of it. It's one of those things I kind of put in the back of my head, might be worth exploring somewhat later. Maybe there's something meaningful and affectively uplifting about her connection with her tribe.
Yeah, there was something there. I also noticed that she was speaking and processing pretty slowly. She wasn't at all agitated or hostile, but her tone was actually almost kind of flat.
Yeah, and that's not very unusual for people who have sort of a unipolar depression that doesn't have much agitation in it. And I noticed that what I was trying to do was to assess her cognitive, her physical, and her social depressive symptoms. I noticed she had some symptoms in each of those areas. And then I asked directly about suicide, and I was glad of that, but I felt a little bad that I never explored the frequency, duration, and intensity of her suicide ideation very completely.
Right. Frequency, duration.
Intensity.
Yeah. But you did ask directly about suicide and about wanting to die or kill herself, which is very hard to do. And you did it in a way that I thought was acceptable. She went with it, she answered you. And you know, the other thing I liked is you asked her about times that she's free of any suicidal ideation.
Which I think is really important, to sort of flow into some positive emotions or positive situations as much as possible during a suicide assessment interview. And you know, when someone admits to suicidal thoughts, it's also important to check on suicidal plan, and the plan can be something that's sort of underneath the surface that you need to ask directly about as well.
I tried 2 times and I realized that I was being selfish. So I guess mostly selfish, like
So you tried a couple of times, and it sounds like after those, your conclusion, what you came to in your mind was that feels selfish and that you're not really wanting to do that? Or?
Well, tried 2 times to kill myself, 2 different occasions.
Okay.
So I just thought, well, 2 times of trying to kill yourself and you didn't die. Why didn't I die? Like, maybe I'm supposed to be here. So, I don't know. I've been trying to think positive, but I don't know. So,
maybe surviving means something.
Yeah.
Maybe that's a message kind of from the universe or from
something.
Yeah.
Wow, that was an interesting exchange. You know, I had the feeling that she really wanted you to ask her more about those 2 suicide attempts.
I think you're probably right, and it was a hard choice. I ended up deciding to go with exploring the meaning of her staying alive, which seemed also important to her. That's one of the challenges in the suicide assessment interview is do you go more for deeper assessments of suicide or suicidal plans or thoughts or even previous attempts, or do you focus a little more strategically on the positive and more hopeful parts of the interview?
Okay, well, let's watch a little bit more.
Well, I guess there's no good reason to commit suicide, but, I don't know what I'm trying to say, but my friend committed suicide because he got caught with a can of chew. He got kicked off the wrestling team.
Okay.
Yep, he shot himself in the head.
And as you say that to me, I think that it sounds like you feel both sad and a little bit angry that he killed himself.
Well, I'm sad. Don't get me wrong. He was a good kid, but it makes me angry because you hurt a lot of people when you take your life. Like, who are you to take your own life? Like, you are hurting your family, your friends. I don't know. So.
Yeah. So I hear you saying reasons to live. One is suicide, you kind of hurt people, maybe even people you don't intend to hurt. Another reason is you've got a brother who you think the world of and you want to help him in his life.
Yeah, I guess I don't want him to end up like me. So.
I just want to check in with you on maybe a little plan for you to stay safe, because I know you've had some thoughts about suicide. It sounds like for the most part, let me know if I've got this right, that for the most part you're pretty clear that you want to live and move forward toward your dream and be a positive influence with your brother. I got that right? That's the main thing. Now, if you were in a situation and you were feeling suicidal, what would help you feel better?
That's a really hard question, because when something really gets me down, and I don't really think about what makes me happy.
Yeah.
Kind of pessimistic in some way.
But the good thing is, right now, you're at a 3 or a 4, so you're not all the way down there at a 0 or a 1.
Yeah.
So right now, when you're feeling a little better, what do you think? What could you remind yourself? Oh, here's what I think I should do when or if I start to feel more suicidal. What would be a healthy thing you could do?
Well, I'd say eat, but that's not too healthy.
Well, it depends on what you eat, I guess.
Well, I binge eat sometimes.
So maybe having a small, nutritious meal.
maybe working out or
Okay.
singing karaoke or something.
Working out, singing. Okay. Those would help. Would it
Yeah.
help to call somebody? Talk with a friend?
I don't really like to talk to people about things they've never went through.
Okay.
They don't understand. They can sit there and be like, yeah.
Anybody on your list of friends who might understand?
Nope.
Nope. Not even the person who was on the phone with you for 3 hours?
They'd be able to understand, but I'd rather call my sister because
Okay.
we grew up together. We know what we went through. So,
Okay. So the possible things you might do is you might work out, you might sing, you might call your sister. Anything else that would help? A tiny bit. Write some good poetry.
yeah,
Yeah?
yes, poetry.
You know, one of the things I just want to say, and then we'll probably stop here in just a minute, is that, it's hard to know when people are going to feel down, right? And so it's good to have a plan ahead of time for what you're going to do, because when you're feeling down, then sometimes you're not very creative and you can't think of all the good options. So what I'm wondering is if you and I can agree that if you have a really down time, that you will try working out, singing, calling your sister, writing poetry, and maybe even add that, to, if you're really, really terribly suicidal, maybe you can call 911 to get some help.
Yeah.
So, this section is really tough. And this whole enterprise of suicide assessment is tough. People are unique, and there is no exact formula for assessing suicidality. I really appreciate the way you work to make the assessment a positive, therapeutic experience, but it's also a scary endeavor.
It was stressful and challenging. Tommy, I think, is a very interesting and complicated young woman. It's hard. I think at times she was very cooperative with me, and there were other times when she was much more challenging. She was a bright young woman. There are a lot of factors mixed in there. I think I probably, if I erred on one side, it was toward being more positive and focusing on maybe more therapeutic questions and what's going well for her, and maybe ignored a little bit of the negative side. One interesting thing that I didn't bring up earlier is that when she talked about her suicidal plan, which had been in the past, and that was a good thing, she also was talking about an underlying motive, and that's often the case with a suicide plan. And for hers, it was a little bit of a revenge motive, a little bit of a send a message to my parents motive. And so I think that's a place where you can take the opportunity to turn a discussion about a plan into something that's more therapeutic and help her focus on how could she give that message to her parents without having it involve anything to do with suicide.
So even though every suicide assessment is unique, there are some factors that should be considered in each interview.
That's absolutely true. And now if you look at the slide, you can see that the first part of a comprehensive suicide assessment interview involves evaluating suicide risk factors. And oftentimes you don't do all that directly, but you find out about the different suicidal factors that may be operating. Typically you do a depression assessment because almost always there are some depression symptoms. You do an exploration of the suicide ideation. You ask directly and frame that in a way that the client can answer truthfully. Also, you explore the suicide plan and move on to trying to determine whether or not the client has a high level of suicide intent. And one of the ways of doing that is to check into their reasons for living. And then the last categories are to try to infer the client's level of self-control. And one way of doing that is to try to develop a collaborative and cooperative safety plan between you and your client.
So if we were going to do a little summary, Tommy has tried suicide twice by her own account. She has a good friend who killed himself. Her family background includes some substance abuse and probably some physical abuse and a very serious addiction problem that Tommy herself has. So certainly she's in a high-risk population. But on the other hand, she's future-oriented and she's in a setting that's structured and is providing her with opportunity to work on vocational skills and on her sobriety.
What you're saying reminds me of the fact that we need to talk about decision making. And that can be one of the most stressful and tormenting things, I think, for a mental health professional, is deciding, well, how do I act in this particular situation? I think because of the things you said, including the fact that she has a pretty high mood rating and she collaborated on a safety plan, that in fact, I probably wouldn't go toward hospitalization. But it's really important to integrate or to weave in some documentation of what you're doing and some consultation with other professionals in order to protect yourself from liability and to make sure you're doing a thorough, comprehensive suicide assessment.
And you know, that not only brings us to the end of this section, but to the end of the DVD.
You know, one thing I'm struck at the end of this whole production is just how much there always is to learn and how complicated individuals are and how many different ways you can look at the clients with whom you're working and how many different ways there are to approach the clinical interview.
You know, if I was going to offer a summarization of that, I'd pretty much say you think that it's a lifelong learning process.
You'd be pretty much right about that.
Okay, I know I said I was going to end that in this video after the interview segment, but I thought about it, and there was one thing I did want to share with you in terms of what you could